hypocalcemia in detail. So, first, we are going to consider the causes of hypocalcemia, which may be many. The most important ones are hypoparathyroidism, vitamin D deficiency, chronic kidney disease. So, hypoparathyroidism can result after thyroidectomy or parathyroidectomy because of autoimmune processes. Vitamin D deficiency could be nutritional because of chronic liver disease or chronic kidney disease. Then chronic kidney disease again leads to a secondary hyperparathyroidism. So these are all the important causes of hypocalcemia, and we have seen other important causes as well. So let us move on to the clinical features. So with hypocalcemia, you will notice that there is an increased excitability. So this causes neuromuscular irritability. When we will consider the case of hypercalcemia, you will see that that leads to weakness and fatigue rather than excitability. So here, how this excitability presents clinically is that the patient will have perioral tingling, paresthesias, muscle cramps, carpopedal spasm technique. We'll see what all this. In severe cases, the person may also develop laryngospasm or seizures. The signs of hypocalcemia that we look out for are the Chvostek sign and the Trousseau sign. We'll see a picture in a while. And on ECG, you may have a prolonged QT interval. There's a increased risk of arrhythmia. The arrhythmia that is most common with an increased QT interval is a torsades de pointes. So Chvostek sign is in cases of neuromuscular irritability where there is a increased excitability of the muscle. Just tapping the muscles on the cheek would lead to a contraction, and this sign which is being seen to the Chvostek sign. In Trousseau sign, when we inflate the BP cuff, a carpal spasm, a spasm of the hand muscles is observed. This is also known as a Trousseau sign or a carpopedal spasm. All right, so here we have an ECG where the normal QT interval is of 360 milliseconds and is increased in cases of hypercalcemia, and this may further lead on to torsades de pointes, which may be a fatal arrhythmia for the patient. Now, the investigation that we would be performing include total and ionized calcium. Whenever we see calcium, we would also consider albumin. To evaluate for the cause of this hypocalcemia, we'll also consider phosphate, magnesium, PTH, and vitamin D levels, and the renal function. Now, acute symptomatic hypocalcemia requires IV calcium gluconate, whereas when it is chronic, oral calcium and vitamin D supplementation is required, and we should always try and correct the underlying cause. Now, let us move on to a discussion of hypercalcemia. So, the most important cause of hypercalcemia is hyperparathyroidism, which is most commonly primary. That is, there is a tumor in the parathyroid gland, most likely an adenoma, which is causing an increased release of parathyroid hormone, which is causing hyperparathyroidism, leading to hypercalcemia. The other important cause of hypercalcemia is malignancy, where parathyroid hormone related peptide is released by the tumor, leading to effects similar to parathyroid hormone and a hypercalcemia. These two are the most important causes of hyperparathyroidism, accounting for about 90% of all the cases. Other causes would include vitamin D intoxication, thiazide diuretics, lithium, tertiary hyperparathyroidism, and prolonged immobilization. Now, to remember the clinical features, we have this mnemonic, which we have been studying from the very beginning of our MBBS years. Stones, bones, groans, and psychiatric overtones. So these patients develop renal stones, they develop bone pain, fractures, and constipation, nausea, vomiting, peptic ulcers, also pancreatitis, some neuropsychiatric conditions, confusion, depression, coma, and in cardiac condition, they have shortened QT intervals. We saw in hypercalcemia, they were developing prolonged QT intervals. So the opposite is true in hypercalcemia, they develop shortened QT interval. So here we are seeing a shortened QT interval. This can further lead on to life-threatening arrhythmias. The investigations, again, we'll perform a total and ionized calcium, phosphate, magnesium levels, PTH, vitamin D, and renal function test, and ECG. So for mild asymptomatic cases, we may just provide them hydration and treat the underlying cause. For severe symptomatic hypercalcemia, that is the one which has neurological symptoms or arrhythmia, we correct them with IV fluids, loop diuretics, bisphosphonates, calcitonin, and if it is refractory, with dialysis. So remember that hypocalcemia leads to spasms, seizures, and prolonged QT, whereas hypercalcemia is stones, bones, groans, psychiatric overtones, and a short QT interval.